Hey, good morning, everyone. Once again, welcome you all in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, I am pediatrician by profession and teacher by passion. We are continuing this amazing series of INI SS Neonatology Rapid Revision. In part 1, we have discussed neonatal neurology. Hope you liked it. Okay, so actually we are discussing only high yield points from these topics. I'm not completely revising these topics for you because it is very vast. Just I'm focusing on ultra high yield topic. Hope you like it. Today in this session, we will discuss neonatal recipe part. Okay, we will not be touching upon pediatric respiratory disorders. We will just be touching upon neonatology, respiratory disorders, and different conditions. Okay, what I want from all from you is 100% attention of yours because this is ultra high yield. What I'm discussing is each and every point is either past MCQ in NEET SS or INI SS or potential MCQ. Okay, so you will find at least 20 to 30 MCQs which are potential. Keep your 100% attention in this presentation. Okay, without further delay, let's start our presentation of neonatal respiratory disorders. Okay, so first thing first, we are here for lung development. So this is important area, lung development. Generally, they ask lung development. So what is the mnemonic? EPCSA. Okay, somehow remember this. E for embryonic, P for pseudoglandular, C for canalicular, S for secular, and A for alveolarization. Okay, the duration is very much important. Embryonic period starts from 27 days to 7 week. Pseudoglandular starts from 7 week to 16 week. Canalicular from 16 week to 24 week, and secular is 24 to 36 week, and alveolarization starts from 36 to and it continue up to 2 to 20 years. So any question can be framed according to this timeline, and the sequence is important. Sequence is previous year's question in INI CET. They have asked sequence. Okay, so in human, the lung development begins at 25 day of gestation. Another potential MCQ question. Okay, if you discuss this, embryonic phase that lasts from 27 to 7 week, tracheoesophageal separation is seen. So any tracheoesophageal fistula abnormalities are seen in this phase. Pseudoglandular, which starts from 7 week up to 16 week. In this condition, basal secretory cells, cartilage smooth cells formation occur. Canalicular stage, type 1 and type 2 cells are produced. Very much important. Secular stage, surfactant production is seen. So any problem in secular stage leads to surfactant deficiency. So these timelines are very important. Just remember or keep in a separate notebook. They are just revision material for just before exam. Okay, going to next slide. Okay, so this slide talks about development stage of lung along with CPAM classification. So as you able to see, this embryonic phase is corresponding to type 0 or type 1 of CPAM. Okay, we will discuss the classification of CPAM later, but as of now, this corresponds to type 0 and type 1 of CPAM. Pseudoglandular stage is corresponds to type 2 bronchial CPAM. Canalicular stage again for type 3 of CPAM. Secular stage is for type 4 distal acinar state. So this is important. And macrocystic and microcystic, this is generally not used classification of adjunct, but these are there. Okay, developmental events we have discussed. Formation of tracheal bud in embryonic. In pseudoglandular, this is periacinar gland formation. Canalicular, this is respiratory bronchial superialveolar structures. And secular, formation of secondary septa. Again, previous year INISS question. Formation of alveoli, obviously in alveolar phase 36 week to 2 years. 2 year is very important. This is again previous year's question. Up to till what age alveolar phase is going on? Up to 2 years. So this was all about lung development, which is important in neonatal respiratory disorders. Okay, now we'll discuss respiratory distress. Sometimes they ask definition of respiratory distress, which includes any two. Just remember any two, because this is common thing. We generally avoid remembering this, but it is very important. Anything I'm telling you is potential MCQ, so give your 100% attention if you are here for this an INI revision video. Okay, so respiratory rate more than 60, subcostal intercostal retractions, expiratory grunt or groaning. Any of two is there, so this will be called as respiratory distress. Okay, below down the statements which can be asked directly in exam options, like Silverman score does not include assessment of skin color, breath sounds, tachypnea, but correlate well with mortality. So this is question. Silverman score correlate well with mortality. Okay, Downey's score show good correlation with physiological parameters such as pH, AADO2 diffusion difference, PaO2. This is again statement based question can be asked, and serial monitoring is more important than one time assessment. Okay, I'm giving the crux or important points from these discussion. You have to actually go through all the points which are given in textbook or AIIMS protocol. But what I want to focus you in this presentation, just important points. You can't miss them. Okay, so here we are Silverman Anderson score for expiratory respiratory distress. Okay, so what does it shows? It you have to remember what component of this, like upper chest retractions, lower chest retraction, G-fold retraction, LR nasal flaring and expiratory grunt. They will ask which is not a component of this Silverman Anderson score. Just remember. Okay, score is 0, 1 and 2. It is given in 0, like upper chest synchronized, upper chest legs and seesaw movement. They will ask patient having seesaw movement, score is what is score. Okay, then lower chest retraction, none, just visible, marked. G4 retraction, not visible, none, just visible, marked. LR major flaring, none, just visible, marked, none, audible with or stethoscope and audible without stethoscope. Just remember this score, because at least one question is expected from these two scores. They will give anything, so you have to remember all the parameters. Okay, this is will be easy question if you have revised just before exam, and it will be difficult if you haven't revised it 10 days before exam. Okay, same for Downey score. They will ask the features like cyanosis or lip of mucosa, retractions, expiratory grunt, air entry, and respiratory rate. They will score. We will score it. Score 0, score 1, score 2. Okay, just go through the respiratory rate, that is important, less than 60, 60 to 80, more than 80, and expiratory grunt with other parameters. What I want to convey from this slide is just remember these two scores in neonatal respiratory disorders. These are ultra important. At least one or two questions are expected from this slide. Okay, going forward to next. Respiratory distress. So we generally divide it into respiratory or cardiac disorders in neonates. Okay, all we know clinical signs like respiratory disorder, cyanosis, severe retractions, liver may be pushed down. In cardiac disorders like cyanosis, gallop rhythms, effortless tachypnea, single heart sound will be seen. But what is important is hyperoxia test. This is important previous year question and has been asked multiple times. In hyperoxia test, what we will do? We'll obtain, just see every single word is potential MCQ. We obtain right radial preductal ABG. So preductal is used, not the postductal, that is right hand. Okay, with breathing, while breathing at room air. Okay, first thing this. Then repeat the test with neonate receiving 100% oxygen. They will ask how much oxygen we will give in hyperoxia test. This is 100% oxygen. Time they will ask, that is 5 to 10 minutes, very important. By which method? You can give with any method like oxyhood, CPAP, ventilator based like respiratory support from a ventilator also. So they'll ask how you will do, first thing. Second thing, they will ask how you will interpret. So first, if PaO2 is more than 250 milligram mmHg, that is test is passed. They will ask sometime test is passed. So this test is passed and PaO2 is more than 250 millimeter of mercury are same thing. In this condition, this is pulmonary disease, exclude right to left lung lesions. Second thing, if PaO2 is less than 100 millimeter of mercury, test is failed. That means this is possible cyanotic cardiac cyanotic disease. Generally, duct dependent shows this type of PaO2 value. Initiate PG even, urgent echocardiography is required. If the test between 100 to 250, the test is pass or fail, it is failed. Okay, they give value 120, so this is failed. Okay, so what is this? This should be put possible cardiac disease with good mixing. Okay, example are obstructive TAPABC. Another important previous year's question is PPHN, persistent pulmonary hypertension, can also result in failed hyperoxia test, though it is pulmonary condition. So this question has been asked also. Going forward to next thing, what are the risk factors? Okay, in NEET SS, two questions were there from respiratory distress syndrome and TTNB. They were from a recent NEET SS exam. Statement from the statement clearly. Okay, so all we are familiar with, but for just completion purpose, we are seeing this in respiratory distress disorder. They will give clinical scenario like a patient with first several hours of life, mostly immediate after delivery, distress developed, tachypnea, nasal flaring is seen. Okay, so this is common scenario of RDS. What is the common scenario of TTNB? Cesarean section, born, precipitous delivery, late preterm, early term, gestational diabetes, and onset immediately after birth and resolution within 72 hours. So these two questions were given exactly in this exam. This can be asked. Pneumonia condition can be asked also as clinical point of view, like a patient has fever in pregnancy, chorioamnitis, maternal fever, PROM, premature rupture of membrane, and these are actually onset of distress. Meconium aspiration, they will say full-term patient, post-term patient, basically fetal distress, parental depression, onset at birth with progressive worsening. That is very much important. Okay, so they will give scenarios along with pulmonary hypoplasia. They will say patient mother having severe oligohydramnios, premature rupture of membrane, diaphragmatic hernia. So in this condition, respiratory distress has onset at birth and it is very severe. So based on these statement, any question can be framed and you have to answer in actual exam. Okay. Gastric aspirate shake test. This is outdated, but they sometime can ask. So what is it? Just remember, in this condition, we will say we will take a 0.5 ml of gastric aspirate along with 95% of ethyl alcohol we will take. We'll shake for 15 seconds and keep it for 15 minutes. Okay, if bubbles are positive, it is positive for RDS. So just remember 0.5 ml of gastric aspirate with 95% of ethyl alcohol, shake with 15 seconds, keep for 15 minutes. Bubbles are there, it is RDS. Okay, so going forward to TTNB. So this X-ray and clinical scenario was asked in exam. So potential question, what in TT, generally what happened? Type 2 alveolar cell actively secretes lung fluids via in alveolus via sodium and water follows the chlorides in the alveoli. Okay, with onset of labor, epinephrine level are increases and stimulates enachalon, which leads to absorption of fluid. So basically, epinephrine increases, enachalons absorb the fluid. But what happens in TTN? In precipitous delivery or cesarean section, there is no time for physiological adjustment of these conditions that leads to fluid accumulation and TTNB. So what happened in lung ultrasound? Again, potential MCQ. Double lung point sign is seen, sharp boundary between superior lung field and alveolar interstitial edema in inferior areas. Very much important. They can ask what is double lung point. They can give this image also, and they can ask description of this double lung point. Three potential MCQs can be asked. Okay, imaging condition. Okay, as we have discussed, the finding improve within 48 hours. Complete resolution of perihilar marking may require 3 to 7 days. Again, potential statement based MCQ. X-ray appearance of TTNB has been asked multiple times. Just remember all the things like sunburst appearance, fluid in minor fissures, mildly hyperexpanded lungs, minimal pleural effusion, streaky infiltrates, and mild cardiomegaly. So these things can be asked in exam. Remember, in exam, the important or most commonly asked question, if you make silly mistakes in those topics, it will be actually very disastrous. If any out of the blue question, out of the book question comes and you are not able to crack it, it is okay, but you can't afford to do wrong a simple question wrong, because this is actually very harmful in algorithm of exam. Okay, so going forward to meconium aspiration syndrome. So diagnosis of meconium aspiration syndrome, it generally onset within first 2 hours of life and lasting for at least 12 hours, which is very much important. It's 2 hours start and lasting for at least 12 hours. Need for supplemental oxygen for 90 up to such 92%. And what happen in meconium aspiration? This is flow chart. You need to remember all this. Just remember what happened in meconium aspiration. Atelectasis occur, air trapping, air leak, acidosis, hypoxemia, and PPHN. So just go through this flow chart, but end results will be these three things, which is demonstrated in this condition also. In this condition of mixed atelectasis and local emphysema seen in case of meconium aspiration syndrome. Okay. Going forward to next, RDS. So this is actually very much important. One potential MCQ is neonate with RDS as surfactant pool only 10 milligram mg per kg compared to 100 milligram per kg in term infant. Very much important. And commonly used surfactant, we have surfactant there, but there are new surfactant also. First is leucinectant, surfactant SPB analog, which is important. Second is RSPC surfactant, and third is CHF5633 SPB and SPC enriched synthetic surfactant. So these surfactant can be asked in exam. Okay, so this is diffuse ground glass opacity with finely granular appearance with hypoaeration. So we are all familiar with RDS X-ray. This can be asked. So image B lines are seen in RDS. I think in this image it is not clear, but B lines are seen in USG. Okay, so in India, Servanta, CuroSurf and NeoSurf are available. All we know, dose we have to remember 4 ml per kg, 2.5 ml per kg and 5 ml per kg respectively. Phospholipid you have to remember, in Servanta 100 mg per kg, in CuroSurf 200 mg per kg and NeoSurf it is 135 mg per kg. You have to remember the composition of surfactant. The most common is saturated phosphatidylcholine, and others you can remember, but they generally ask most important. Okay, administration of surfactant all we are familiar with, but generally they are statement based question. So warm the surfactant for 8 minutes if it is held between palm of the giver, and 20 minutes at room temperature. So 8 and 20 minutes are important for MCQ point of view. Don't shake the surfactant. They can ask it. A statement based question, generally it given in 4 aliquots. Okay, so they can ask that suctioning of ET tube should be avoided at least 2 hours following surfactant administration. So these are actually important questions in this regard. Okay, this image can be asked. This is electron microscopy of type 2 alveolar cell showing laminar body. So they can ask label it and what is it? This is laminar body, and in this diagram also laminar body is responsible for secretion of surfactant from type 2 alveolar cell. So this image can be asked. This I think it is potential MCQ. Okay, going forward to surfactant replacement therapy. Okay, so this flowchart is having 3 to 4 questions. Just pay your 100% attention here. If a neonate is 28-week old, less than 28 week, so just will you give surfactant? Just see if the patient hasn't received antenatal steroids or patient is intubated. Two conditions are required. Give prophylactic surfactant just after stabilization, very much important. But what if it is 28-week or more gestation? See if respiratory distress is there or not. Okay, and just see if oxygen requirement is more than 30%. Just remember only 30%. Maybe it may be of CPAP or mechanical ventilation. So 30% is the criteria. This is previous NEET SS question of recent exam. Okay, we have to give early surfactant therapy. So this is actually criteria we have to remember of early surfactant therapy and prophylactic surfactant therapy. Two questions are ultra high yield. Okay, if good spontaneous respiration, no hemodynamic stability is seen, basically, so you have to continue on mechanical ventilation, but normal response is seen, you can continue to nasal CPAP. Again, one more question. When you will give repeat dose? We can give repeat dose after 12 hours of initial dose. Question. If FiO2 is more than 40% of CPAP failure. So these are three criteria after 12 hours. Oxygen requirement is more than 40% or CPAP failure. So you have to remember this. This is ultra high important. 3 to 4 questions are hidden in this simple looking flow chart. Going forward to neonate with respiratory distress. So just algorithm is there, just go through once. Any one question might be expected. So if we see abnormal lung, so we will go to lung condition. Yes, okay. So lung condition means parenchymal lung condition. If x-ray is normal, means parenchyma is normal. Airway finding, like you can see upper airway obstruction. If perfusion, BP, hematocrit is issue, anemia, polycythemia, hypotension, hypovolemia can produce respiratory distress. CVS finding, obviously congenital heart disease. Neuromuscular finding can asphyxia, ICH can give to respiratory distress. Abdominal signs like NEC, abdominal mass can produce respiratory distress. Diaphragm or chest wall disorders, diaphragmatic disorders, and other mixed disorders. So just go through this flow chart once. Apnea. So this is important. Just apnea definition is important. If cessation of breathing is longer than 20 seconds, mark is apnea. But if it is less than 20 seconds, 10 seconds, 12 seconds, so what should be there? In presence of either significant bradycardia, means heart rate should be less than 80, or change in skin color, pallor or cyanosis. So this is and or just remember this definition clearly, be actually clear in your mind. So this is or. Okay, so this is one potential MCQ. Another important question is they will ask what is the half life of caffeine citrate. It is 25 to 371 hours, mean 101 hours. What is the half life of theophylline? Is 13 to 29 hours. Therapeutic drug level of caffeine is 8 to 20 microgram per ml. Therapeutic level of theophylline is 5 to 10 microgram per ml. Okay, dose they can ask, you have to remember, but these four questions are definite previous year question in both NEET SS and INI SS exam. Okay, so how you will approach neonatal apnea? First, basically you have to go for ABC, exclude secondary causes of apnea. If secondary causes of apnea are excluded, this is apnea of prematurity. Start caffeine on aminophylline. If no apnea is there, So they'll ask how long you will continue. We will continue till 34 week of gestation, another question. And stop drug is if apnea free for 7 days, another important question. And if no response, obviously we will accelerate like CPAP and ventilatory settings. Okay, so what xanthine do? So this is actually, they will ask mechanism also. Altered neurotransmission like adenosine and GABA, less apnea or less BPD leads to less hypoxemic event. Modulation of cytokinin release, again this is potential MCQ. They actually modulation of cytokinin release is done by xanthines. For protection of PVL and ventriculomegaly. So long-term improvement in motor outcome at 5 years of age is seen. So this is very much important. Okay, going forward to congenital diaphragmatic hernia. So one question was asked in this recently exam. So what they will ask, I'm just highlighting important thing in this thing. This can be syndromic association 18, 13 and 21 trisomy, and if one syndrome, that is potential MCQ Freiren's syndrome, can be found in 10 to 15% of cases. Potential MCQ, just mark this. Okay, liver herniation. This is keep your attention here. Presence of liver herniation in left side CDH is poor prognostic factor, but not in right side because it is normal finding. So just keep your attention here. Presence of liver herniation in left side of CDH is poor prognostic factor, not in right side. Okay. Low lung volume, less than 30% expected, is also poor prognostic factor. So what are the actually treatment or protocol of CDH? Intubation at birth. You have to keep low peak pressures. Settings PIP less than 25, PEEP 4 to 6 and RR 40 to 60. Important. Sedation is important. Paralytic agent you have to avoid. Insert nasogastric tube, and features of PPHN you have to manage. They can ask be a statement based question. Okay, so if neonate meets stabilization, medical stabilization, you have to do surgery. But what are the medical stabilization criteria? They can ask as a statement based or clinical scenario based question. If preductal SpO2 is 85 to 95 on FiO2 less than 50, blood pressure are normal, lactate is less than 3, and urine output is more than 1 ml per kg per hour, we will call this patient of CDH as stable patient. We will go for surgery, either open or thoracoscopic or Gorex-Tex patch or abdominal wall muscle flap. So you have to remember this ultra high yield. Any clinical scenario can be made according to this. But if these features are not there, just see if neonate meet ECMO criteria, again potential MCQ, PIP more than 28, SpO2 less than 85, or actually pH 7 less than 7.15, lactate less more than 5. So go for ECMO. So in this simple looking flowchart, 3 to 4 questions are hidden. Just pay attention, just pause this video and revise them again. Okay, one potential MCQ is GRD is most common cause of readmission in first year in case of CDH. Repeat question, repeat PYQ. Okay, tracheoesophageal fistula type A, B, C, D, E, all we know. EA with distal TF is most common type C. Okay, just I am highlighting the important or PYQ questions from this. And PO you have to do head and elevation, upper pouch decompression, avoid positive pressure ventilation including CPAP, very important, and high frequency ventilation as a rescue mode can be used. Echocardiogram is required. Okay, so how you will approach thoracoscopic approach and long gap EA in this condition or any difficult condition, delayed primary repair after focus procedure, staged repair and esophageal replacement can be done. So these are the surgical consideration. Post-operative period, you have to do effective ventilation paralysis for 2 to 7 days, contrast esophagogram at 5th or 6th, 7th post-operative day. Immediate complication, they will ask anastomosis leak. is the important PYQ. What you will do in this condition? These they are managed conservatively with antibiotics. Again, important question. They'll ask as clinical scenario. Okay, short-term complication, anastomotic strictures. Okay, how you will do endoscopic balloon dilation and intralesional steroid topical application of mitomycin C. They will ask it because what is the this TF recurrence 5 to 10% cases, again potential MCQ. Long term complication is dysphagia and GERD. How you will manage it? By acid suppression. Tracheomalacia is seen in 15 to 20% cases, requires orthopaxy in 3 to 5% cases. So all things I am discussing are potential MCQ or previously asked MCQ. Okay, going forward to next, bronchopulmonary dysplasia. Before discussing the management part, let's see the diagnostic or definitive criteria of bronchopulmonary dysplasia. Okay, it has been classified according to gestational age. If gestational age is less than 32 week or more than 32 week. Okay, just remember the examination time of patient. At if patient is baby is less than 32 week, we will examine this patient at 36 week post menstrual age after 1 month. If patient is more than 32 week, we will see this patient at 56 days post menstrual age, so postnatal age. So this actually 36 week and 56 days, you have to remember what are the entry criteria in this. Okay, entry criteria is you have to give treatment more than 21% oxygen for at least 28 days. If a neonate received more than 21% oxygen for 1 month, BPD can be classified. Okay, so after that it is simple. We have to classify BPD into mild, moderate and severe. Okay, so what is the oxygen requirement? Breathing room air need for less than 30% oxygen or more than 30% oxygen, and or positive pressure ventilation. Okay, so what they are saying, uh, in this condition, if breathing room air at 36, mild BPD, moderate less than 30% oxygen and severe more than 30% oxygen. Again, very much important. Similar thing is for more than 32 week of gestation, breathing room air at 56 days, need less than 30% oxygen 56 days, and need more than 30% oxygen 56 days. You have to remember this in tandem. Okay, so this is simple to remember. Just pause this video and revise it again. In new definition, this is again potential MCQ question. A new definition has come up. What they say, infant less than 32 week of gestation. Okay, this is for 32 week of gestation. Will follow FiO2 oxygen levels concentration for more than 3 consecutive days to maintain SpO2 in 90 to 95% range. So we'll classify as grade 1, grade 2, grade 3. We'll discuss grade 3A later. Grade 1, 2, 3, we will classify like invasive IPV, NPV, NIPV, nasal cannula more than 3, nasal cannula 1 to 3, and nasal cannula less than 1 liter per minute. So just I am dissecting this table. Just focus on this part. If nasal cannula oxygen is less than 3 liter per minute, there can't be grade 3rd BPD. No. Okay. So nasal cannula less than 3 liter per kg, it can be grade 1 or grade 2. The values are 22 to 29, more than 30, 20 to 70, and more than 70 you have to remember. But it can't be grade 2. Invasive IPV grade 1 is not. Okay, if patient is on ventilator, you can't say it is on grade 1. Very much important potential MCQ. Grade 2 is 21% FiO2 and grade 3rd is more than 21% FiO2. Okay, and CPAP or nasal cannula more than 3 liter per minute, 21%, 22 to 29 and 30%. So 3 to 4 questions are hiding in this table. Again, grade 3rd third ABPD. In this condition, what they will call infant who die between 14 days to 36 post menstrual age from respiratory failure. not attributed to other neonatal mobility will be graded as grade 3rd A BPD. So again, pause this video and revise them again because this is important. Okay, so in this, just quickly see X-ray. In this actually bubbly lungs, CLD, enlarged RV seen. We're not concerned about it. What we are concerned is management part. Okay, so in this antenatal corticosteroids has role. Avoid excessive pressure and volume. Fluid should be less, like 60 to 80, and PEEP should be moderate. They will ask then the parental nutrition can be given. They are giving guidelines according to weeks, 2 to 4 week, okay, more than 4 week. Basically, just go through these guidelines. Basically, they are advising moderate ventilation with low pressure settings. Okay, stroker classification of CPAM, this is important. Okay, type 0, type 1, type 2, type 3, type 4, tracheobronchial tissue, distal bronchial and proximal bronchiole, terminal bronchioles, and distal alveolar and acinar and alveolar. So these are origin. The most common is type 1, again previous year question. The most least is type 0, previous year question. Rarest form is type 0, small cyst, 0.5 centimeter diameter. Again, most question they have asked. Okay, multiple cyst with solid area resembles extralobar pulmonary sequestration. Again, potential MCQ. Mixture of solid and cystic area, large cyst more than 7 centimeter. So CPAM classification, stroker classification is there. They can ask. They can ask which is least common, more common, cyst diameter, and they can ask frame any question from CPAM. Okay. Going forward to next, PPHN. So I'm just highlighting examination finding: labile oxygen saturation, single S2, systolic murmur of tricuspid regurgitation, preductal SpO2 greater than postductal by 10% or more. But statement based question: absence of pre-postductal SpO2 difference does not rule out PPHN. Again, very much important. Okay, so PPHN, this has been management or the distribution. Basically, pathophysiology is classified as mal-developed PV with normal parenchyma. Just see the highlighted things because this can be asked. Alveolar capillary dysplasia, FOXF1, this gene can be asked. Okay, potential MCQ. SPD, ABC, A3 can be asked. Genetic trisomy 21, TBX4, CDH, and IDM, CDH, and SSRI NSAIDs can be asked. Okay, so pulmonary venous condition like cardiac dysfunctions, left to right shunt, ASD, TAPVC, TTS, left side obstruction. So just go through this flow chart again. Okay, so again management, just I'm highlighting important thing. Anticipate PPHN, mechanical ventilator, PaO2 less than 80 on 100% FiO2 or pre-post SpO2 difference is more than 5 absolute points. So this is mechanical ventilation criteria. Okay, INO. What is INO requirement? Is oxygenation index is more than 25. You have to rule out other congenital heart diseases. So this is nitric oxide actually algorithm, which is important. How you will initiate 20 ppm, previous year question. When you will start when OI is more than 22 to 25. Complete response, again question, if increase in PaO2 is more than 20. Okay, wean FiO2 first to maintain SpO2 91 to 95. This is potential MCQ. Wean, how you will wean? Wean nitric oxide 5 ppm every 4 hours until 5 ppm, then slowly at 1 ppm every 4 hours. If this having partial no response, PO2 same or less than 20 millimeter of mercury, you have to go for HFO surfactant and prepare for ECMO if available. So just go through this. I am going very fast in this actual discussion because we have to cover a lot and this is ultra high yield. So you have to see this video again for complete understanding. Okay, so drugs, sildenafil, like for PPHN, this is PD5 inhibitors, ano-mediated vascular dilatation. So this is important. Mineral, This is phosphodiesterase 3 inhibitors act via CEMP. So these two questions can be asked. You can go through whole this table if you want. These are two previous year asked question I have highlighted. Okay, so in management of PPHN, what you have to do, if CPAP, HFP, and early surfactant administration, what is the first line they will ask according to Nelson? If INO, if oxygen index is less more than 15 despite optimum ventilation, so this is first line. Okay, what is the second line? If oxygenation index is more than 25, adjuvant therapy are the second line. What are the adjuvant therapy? First you will start ilioprost, then treprostinil, and then sildenafil. Okay, so these are the sequence you have to go for adjuvant therapy. These are second line therapy. After second line therapy, see if decreased myocardial dysfunction is there, add milrinone. So this can be asked as potential statement based question or scenario based question. Restrictive ductus or right heart failure, consider PGEV1. What is the third line of drug? This is bosentan. Again, very important given oral clinical based scenario. If OI more than 40 on serial ABG and significant cardiovascular instability, go for ECMO. So this small looking flow chart having 3 to 4 question at least potential MCQ, just revise them. Okay, so this is Bocheldek hernia, this is right lung pulmonary interstitial emphysema, and this is pneumomediastinum. Just pause this video and revise them. These can be asked as image based question. Neonatal pulmonary physiology by disease state, again ultra important. Normal compliance you have to remember, resistance time, FRC. I will be not going into detail of the discussion. Will discussion this will critical care module. So just see what happening in this. Just pause this video and revise. Try to understand. I'll make a separate video on this pulmonary physiologies. Okay, so this is end title capnograph. You have to remember phase 1, phase 2, phase 3, phase 4. Okay, again we'll discuss various capnographs in critical care part. Okay, this can be potential MCQ. Human lung field with compared to body field. Lung field is sodium 150, potassium 6.3, and pH 6.27. Just remember these three value. Amniotic fluid you can compare, but just remember, if you want to remember anything, just remember three value. They can ask any value. It will be actually beneficial for you if they ask. You can mark it correct. Okay, so in this busy looking table, what I'm trying to convey you, a hydrophobic surfactant protein SPB and SPC, they leads to respiratory distress syndrome. Very much important. Hydrophilic surfactant like SPA, SPD, these compromise host defense and impaired ability to modulate immune response. Development of capillary pulmonary bed, variable degree of impaired gas exchange seen, fetal lung fluid pulmonary hypoplasia seen. So these are important as potential impact of premature birth on lung development. Okay, this is role of pulse oximetry, which is very much important. Just see if postductal SaO2 is more than equal to preductal SaO2. Potential exam question: TGA with pulmonary hypertension or TGA with coaction of aorta. Very ultra high yield. This table is ultra high yield. Preductal is more than postductal. So what are the possibilities? PVR is more than SVR. Duct dependent lesions, anatomically pulmonary vascular disease. So PDA, PPHN, HLHS, IA, aqueduct coaction you have to remember. But what happen if preductal and postductal are normal in case of respiratory failure? Intrapulmonary shunt, cyanotic congenital heart disease, duct dependent pulmonary blood flow, and PPHN are the important consideration. You have to remember these. All clinical scenario has been asked multiple times, and this is ultra high yield. You have to remember it. Okay, so mediastinal masses etiology by location can be asked because this is actually a previous year question. Anterior mediastinum actually contains thymic hyperplasia, thymoma, and cystic lesions are seen like thymic cyst, lipoma, and thiomyolipoma. In middle mediastinum, congenital foregut duplication cyst, bronchogenic cyst, lymphoma, and metastatic disease can be seen. In posterior mediastinum, neuroblastoma, ganglioneuroblastoma, schwannoma, neurofibroma, malignant peripheral nerve sheath tumor. So these are actually potential MCQ. You have to go through this list one. This can be asked. Asphyxiating thoracic dystrophy, Janus dystrophy it is called. So the features are hypoplastic lung, downward displacement of liver and spleen, cystic renal disease, bell-shaped thoracic case. So any one of the feature can be asked, all or except thing. Okay, so going forward to next, bronchogenic cyst. In this condition, what they will ask, they have connection to bronchial tree, partial bronchial obstruction like emphysema, complete bronchial obstruction like collapse, and esophageal compression or airway compression as seen in these two X-ray. So bronchogenic cyst can be asked. Detail you have to remember. I'm just touching upon bronchogenic cyst. Okay, characteristics of chylous effusion, they actually, this is PYQ. So in this condition, what they will ask, they actually ask triglyceride are more than 110 milligram per deciliter. Other thing they can ask, cell are more than 1000, lymphocyte proportion is more than 80, pH 7.4 to 7.8, cholesterol 65 to 220 milligram per deciliter, albumin and total protein you have to remember. But previous year is triglyceride question. Okay, going forward to CPAM. So we have discussed CPAM. Just remember cyst size. This is more polished version of CPAM classification. Cyst size less than 0.5, more than 2, 0.5 to 2, less than 0.5 and up to 7. Okay, so you have to remember like origin from tracheobronchial tree, distal bronchi, proximal bronchioles, multiple bronchial type structures, solid cyst. Okay, and affected usually die at birth at 0. It is more severe and less commonly found. This is most common, this is least common, and this is most severe. Okay, malignant potential is seen in type 1 and strong malignant potential seen in type 4. Okay, so these are actually important question. Going forward to in sequestration, intralobar sequestration and extralobar sequestration. Expect one question from this. Often diagnosed in later in childhood or adolescent due to recurrent pneumonia. Okay, male to female ratio is 1.5 to 1. Common site is lower lobe. Does not communicate with airway. Venous drainage to the pulmonary vein is seen. No separate visceral pleura is seen. In contrast to extralobar sequestration, often diagnosed with fetal neonatal period, may spontaneously regress. Male to female ratio is 3:1, and associated anomalies, again important question for extralobar sequestration, they are CDH vertebral and GI colonic duplication, ultra high yield question, potential MCQ, just mark it. Common site are left lower lobe. Arterial supply from aorta does not communicate with airway. Venous drainage to bronchial veins. Oven visceral pleura, associated pleural effusion, and may communicate with the gut. So these are potential actually question from this sequestration. There we conclude neonatal respiratory disorders. Actually, just touched important points in this neonatal respiratory disorder. You have to read whole respiratory part of neonatology, but you can't miss these ultra high yield topics which we have discussed. Okay, so the purpose of revision series is just to highlight important or ultra high yield most forgettable thing which can be useful in your exam. We will be continuing this series of neonatal fast track revision. Comment down below if you have any suggestion or you want any other thing for exam point of view, like MCQ or any other thing. Okay, hope you like this video. If you like this video, do share, like and subscribe. We will meet in another video of this series.